Cystic fibrosis. It is a multisystem autosomal recessive disorder. Affects GIT, respiratory system, genitourinary tract, sweat glands. Most common life-limiting genetic disorder is cystic fibrosis. What is the most common life-limiting disorder? Cystic fibrosis. CFTR gene. That is CF, transmembrane regulator. Location chromosome 7q. Codes for CFTR protein, chloride channel. Most common mutation is delta F508, depletion of phenylalanine at 508 position. Mucoviscidosis, thick mucus secretion in body. So here is a healthy airway. Healthy smooth muscle, lumen, tracheal muscle. Cystic fibrosis, here you can see mucus secretion, inflammation. Respiratory epithelium. So this is the respiratory epithelium and this is a healthy airway, intracellular and the lumen. You can see chloride is going from intracellular to the lumen through the CFTR channel in a healthy airway. And in cystic fibrosis, there is thick mucus over the epithelium. Clinical features, GIT. This is the in the GIT tract features earliest. You have meconium ileus, incidence 10 to 15% patients. Virtually diagnostic of cystic fibrosis. Investigations, clinical features, Inspission of thick meconium in ileum. Intestinal obstruction at ileum presents with delayed passage of meconium and abdominal distension. Contrast enema. Microcolon plus filling defects, distended small intestine due to obstruction, proximal to terminal ileum plus air fluid levels plus ground glass appearance. In contrast, edema. You see microcolon with filling defects, distended small intestine due to obstruction, proximal to terminal ileum, air fluid levels plus ground glass appearance. In older children, you find constipation, which is impaction of fetal matter in distal ileum. DIOS, distal intestinal obstruction syndrome. It is known as distal intestinal obstruction syndrome. Constipation in older children, impaction of fetal matter in distal ileum. Pancreatic insufficiency. 85% cases initially exocrine and later becomes endocrine. Exocrine features, you see steatoria, vitamin A, D, E, and K deficiency. Endocrine features, second decade, you see diabetes mellitus. Rectal prolapse, older children, rare due to early supplementation of pancreatic enzyme. Rectal prolapse in older children, rare due to early supplementation of pancreatic enzyme. Respiratory tract infections, recurrent infections by Staph aureus, which is most common, H. influenza type B. Pseudomonas in late childhood adults cause mucoid secretions, forms biofilm and antibiotic resistance. Burkholderia cepacia, increased risk of death. Bilateral nasal polyps. In early childhood, you see recurrent tract infections by Staph aureus and Haemophilus influenza type B. Other features: biliary tract, thick biliary secretions, bile outflow obstruction, biliary cirrhosis, neonatal cholestasis. Other features in the biliary tract, you see thick biliary secretions, bile outflow obstructions, and biliary cirrhosis and neonatal cholestasis. Genitourinary tract, males, failure of Wolffian duct development, azoospermia, infertility. Females, decreased fertility rate. Sweat glands, inactive CFTR protein, increased loss of sodium chloride in sweat, decreased reabsorption. Salty skin on kissing, frosting of skin, predisposed to hyponatremic, hypochloremic metabolic alkalosis, increase in sweat chloride glands. Biliary tract, thick biliary secretions. Other features are in biliary tract, thick biliary secretions, bile outflow obstruction, biliary cirrhosis, and neonatal cholestasis. Genitourinary tract, males, failure of Wolffian duct development, azoospermia, infertility. Females, decreased fertility rate. Sweat glands, inactive CFTR protein, increased loss of sodium chloride in glands, and decreased reabsorption. Salty skin on kissing. Frosting of skin, predisposed to hyponatremic, hypochloremic metabolic alkalosis, increased in sweat chloride test. Management of cystic fibrosis diagnosis. Clinical criteria positive for anyone. Confirmatory test lab test is done. Typical clinical features respiratory, gastrointestinal, and genitourinary. History of cystic fibrosis in a sibling, autosomal recessive. Positive newborn screening test is immunoreactive trypsin test, IRT. Laboratory evidence. Anyone positive lab test confirms cystic fibrosis. 2 sweat chloride concentration more than 60 milliequivalents per liter on separate days. Identification of 2 cystic fibrosis mutations. 1 abnormal value of trans epithelial nasal potential difference. So, what is the laboratory evidence for cystic fibrosis? Any one positive lab test confirms cystic fibrosis. 2 sweat chloride concentration more than 60 milliequivalents per liter on separate days. Identifications of 2 cystic fibrosis mutations. 1 abnormal value of trans epithelial nasal potential difference. Pilocarpine ionophoresis sweat chloride test. Pilocarpine administered into skin of baby using electrodes. Pilocarpine administered into skin of baby using electrodes. Baby's sweat collected in collective device which process it for chloride levels. Baby's sweat collected in collection device which processes it for chloride levels. So this is the collection device and electrodes and sweat chloride test. Treatment. Treatment, respiratory care, airway clearance, antibiotics and prophylaxis, airway clearance, physiotherapy, mucolytics, inhaled hypertonic saline 3%, human recombinant DNAs, human Dornase alpha, airway clearance, physiotherapy and mucolytics, inhaled hypertonic saline 3%, human recombinant DNAs, human Dornase alpha, antibiotics co-amoxicillin, drug of choice, amoxicillin plus cavulanic acid, fluoroquinolones and azithromycin. What is the antibiotic of choice in cystic fibrosis? Co-amoxicillin, drug of choice. That is amoxicillin plus cavulanic acid, fluoroquinolones and azithromycin. Prophylaxis. For Pseudomonas infection, 3 times a week decreases colonization. Inhaled tobramycin, estrionam, oral azithromycin. Prophylaxis against Pseudomonas infection, 3 times a week decreases colonization. So what do? Inhale tobramycin as estrionam, oral azithromycin. Dietary measures. Diet, you have to take high fat, proteins and calories. Salt supplementation more during dehydration. Pancreatic enzyme supplements, enterically coated microspheres. Fat soluble vitamin supplementation, A, D, E and K. CFTR modulators increase activity of CFTR channel. Ivacaftor more than 2 years. Ivacaftor plus lumacaftor more than 6 years, useful in delta F5808 mutation cases. Ivacaftor plus tezacaftor more than 12 years. Ivacaftor plus tezacaftor plus alexacaftor triple combination therapy covers most mutations. CFTR modulators increase activity of CFTR channel. Ivacaftor more than 2 years. Ivacaftor plus lumacaftor more than 6 years, which is useful in delta F508 mutation cases. Ivacaftor plus tezacaftor more than 12 years. Ivacaftor plus tezacaftor plus alexacaftor triple combination therapy, which covers most mutations. In next video, we'll see fetal circulation and introduction to congenital heart diseases.